Good afternoon, everybody, and thanks for joining us today for this presentation. It's called Clearing the Path, Identifying and Eliminating Barriers to Reporting, Investigating, and Defining Sexual Misconduct and Boundary Violations in Physical Therapy. And if you didn't have a chance to scan the QR code, we'll have opportunities in the near future to do that. We want to welcome our two presenters, Jennifer Wissinger and Kristina Lounsberry. Jennifer is from Ohio, and Kristina is from Louisiana. And they have been leaders and members of our Sexual Boundaries Task Force that's been in place and have done such wonderful work in such a short period of time. So they're here to present really some great information that has been gathered over time. And if you haven't had a chance to go to the FSBPT website, I think we'll be promoting that. There's the resources that are going to start populating in our website. It will be helpful to all of you. I will be monitoring the chat room. We do want to make this a dynamic seminar, so I'll be keeping an eye on your questions, and we'll either interrupt during the seminar or we'll leave them to the end, depending. So please put your questions, things that are on your mind in the chat. And for now, we'll turn it over to Jennifer. Thanks.
Welcome. Thank you, everybody, for joining us today. We're going to go ahead and jump right in to the next slide. We want to see who's with us today. So go ahead and jump back into the Slido poll. Let us know which area you represent. All right. We've got a lot of people. Oh, a lot of regulators. Okay. I always love to see how the poll changes so quickly. We know we have educators with us. We have board members here today. All right. Just a few more people, I think, to kind of weigh in and kind of round out who's represented today. Oh, the administrative staff is well represented. Thank you for joining us. All right, well, thank you so much. Let's jump into the next slide. Now we want to know where you're joining us from. So let us know which jurisdiction you're joining us from. This can be just your two-letter state abbreviation. Oh, Ohio, thanks everybody. Ooh, Ohio, Pennsylvania, Mississippi. Oh, someone from Canada, all right. We reference a lot of material out of Alberta, so that's really great that you're able to join us today. Beautiful New Jersey. Great how you were able to give that little disclaimer there. All right. Well, thank you everybody for joining us from all over. Well, in 2020, the FSBPT formed a Boundary Violations Task Force, and it was in response to information that was gathered about this area as an important area that we needed to be looking at more closely. And according to a 2021 poll by the FSBPT, 63% of regulators reported an increase in sexual misconduct complaints. This number is alarming, but staggering that it's such an issue that needs attention. So we hope that we can help address some of the issues around this topic today. Next slide. We hope that by the end of the webinar, you'll be able to identify at least 2 barriers to reporting in your jurisdiction's website or practice act, describe at least 2 strategies to eliminate the barriers in your area of regulation or practice, and select at least 2 resources for follow-up and benchmarking progress in this area. Next slide, please. So our task force really looked at getting information from the websites of jurisdictions that are already out there and what information is available for reporting boundary violations or sexual misconduct. And we took the approach of if we were a patient trying to file a complaint, but it also led to lots of discussions about we as clinicians also have a duty to report if we see or know of any such violations as well. And that led us, we wanted to direct you to this newer resource available on the FSBPT website, highlighting our professional and legal responsibilities related to reporting unprofessional conduct or violations of law. And you can take this brochure, it's in a template form, and add your jurisdiction specific information to it. The contact information, where to look on the website, things like that. But it's a really nice resource that walks you through what should you do and helps you through that process to make a complaint if you're the clinician too, which I thought was really nice. Next slide, please. So that brings us to the idea of how do we report? How does the public report this information? And are there any barriers related to reporting this information to our jurisdictions? Next slide. So as a task force, the members were assigned to review several jurisdictions' websites that were not their own jurisdiction. And they were asked to consider if they were a victim of sexual misconduct, needing to file a complaint with the board, how easy was it to get to the information that you needed if you were in that situation? Next slide.
And Jennifer, I hate to interrupt you so early, but there was a question in the Q&A that asked if you could differentiate between sexual abuse and sexual misconduct. I'm not sure if this is further along in your slide deck, but
we're not quite there yet. Right. But let's keep that in mind as we get a little bit further into the discussion, and that might come up again where we can talk a little bit more about it.
Thank you.
So one of the first things we looked at was how far deep into the website do we need to go to get to find where to file a complaint or find information about the complaint and actually input the information needed to formally file. And as you can see from our graph here, our chart here, there were several jurisdictions that in one click, you could get to where you needed to file a complaint. Most of them were in that 2 to 3 click range, but then several were way up in the 10 plus clicks deep into a website to figure out where to go, what to do, what information to access, and actually put the information into the system. So this was an eye-opening as a barrier to how difficult it was to get to this information in the jurisdiction's website. So one of our first takeaway tips as a task force, kind of compiling this information that we can relay back to the jurisdictions, is a quick solution would be to have a quick link on your jurisdiction's main homepage for how to report a complaint of inappropriate action on a licensee. And I gave the next slide has a screenshot of what Ohio has on there. It's just on their first page. It's very clear where to file a complaint, and you just click right there on the homepage. So something like that could help eliminate that barrier for you. Next slide. The next question we looked at asking was, is it clear on the website or on those pages whether the complaint would be filed anonymously, confidentially, or if it would be open public record once you've made the complaint? And as you can see, there were some where it is clear that it's anonymous. Many are confidential. A lot, the information immediately becomes public record, but then the majority, it's really not clear how that information is handled, which is, if you think about it from the complainant side, if I'm already struggling with the need to make a complaint like this, and then finding out that it's going to be immediately made public record, everyone's going to know that I filed this complaint, or it's not clear whether it will be public record or not, I'm going to pause before I before I continue. And that could be a barrier to reporting and following through with the complaint. Next slide. So our takeaway tip in this area would be for you as a jurisdiction to kind of consider how you're classifying the reports made for boundary violations. And are you making it clear to the person on the other end filing that their report would either be anonymous, confidential, or public record? And how do you explain the need to have contact information so that you can follow up with an investigation and fully investigate the report, but how that information about contact would be kept private, confidential, or how it's handled so that it's very clear to the person filing. Next slide, please. So here is an example from the Virginia page about how they are describing their process and how they can have an anonymous complaint filed if the individual wants to remain anonymous, and what their processes are. So it's very clear. The person can see that they can submit the information anonymously, and they can. It's just very clear from the beginning. And then there are alternative ways to file. There's ways that they can print it and fill it out, so it's not just on the website. So things to consider for your jurisdiction. So that takes us to another question here on the next slide. What do you think about the language on your jurisdiction's website about this? And do you think you have any language that could be a barrier to the individual wanting to report some complaints in the area of sexual misconduct or boundary violations, whether it's related to how clear the information is, whether they could, the information would be made public record, whether it would be confidential. Is it confusing for the complainant trying to navigate the website and figure out where to get to the information they need? We have a lot of people in that maybe range. So that tells me that it's not super clear if the information is clear on your website or not, which is probably pretty common. I think we expected that. And that's kind of why we're here today, is to just get you thinking about some of these so that you can start to maybe implement some change or clarify some things for your own jurisdiction. All right, so a lot of maybes there. Let's head to the next slide. So in reviewing the language on the websites, when we looked at what other language might be a deterrent to someone who's filing a complaint, we found some language that really stuck out. One example was giving the complainant that any information they would supply would become public record, and that we strongly urge you to not submit sensitive personal information on these forms. Well, if you're submitting information or a complaint about a sexual misconduct incident or a boundary violation, you don't get more sensitive or personal than that. So reading that language, being someone wanting to file a complaint, I'm already going to be stopped in, do I really want to proceed with this? Because this is very private, very personal, very sensitive, but your website's telling me not to include that type of information in here. That's a huge barrier. Some websites we found require notarized signatures on the form in order to formally file the complaint. That's a huge barrier, right? That's such a challenge for someone to even access a notary very easily, but then to go and have to share this information with the notary because they have to be able to know what they're signing. That could be a huge barrier to someone filing a report. And another example is if the complaint is open for investigation, we just want you to know this could take a really long time because we get lots of these all the time. So we get up to 3,000 complaints. It's going to take a long time. We'll get to it when we get to it. That kind of language is really a deterrent to someone who needs to make a report like this. And it really discourages someone from reporting in the first place. So again, think about how that language is affecting the person filing. So the next slide gets a little bit more to how we're labeling the people who are involved in the steps of this process. So I've been using the word complaint or uncomfortable or inappropriate or sensitive. Those types of words could kind of have a negative connotation or kind of make the person feel negative about the situation and the scenario and trying to do something about it. So something to think about in how you're wording the sections of your website and the language that you're using regarding the individual and the situation that's happening. So the next slide kind of gives us some language to consider, like the claim or the claimant instead of a violation or the report of the victim or things, language that can be kind of have a negative connotation. And then more open-ended things like describe the situation that you would like to report instead of what is the violation you're reporting? What is the misconduct that you're reporting? Because again, it has the negative connotation around it. So those are just some other things to consider in your directives on the website. Next slide, please. So this brings us to how are we defining? We're talking about language and the words that we're using. So how are we defining what these violations are? And this might get a little bit to the question that came up earlier about differentiating the levels of misconduct and levels of violation. So we could go on and on about all of the types of possible violations. And a lot of our practice acts do have sections that very clearly list specific types of contact or different types of relationships. We couldn't possibly cover all of that in today. So we started with a few of the basics. The next slide will show we started with just how we're defining patient. Because especially with some of the misconduct situations where we have a clinician and a patient in a romantic relationship, it becomes important to understand, well, is that individual a patient of the provider, or when are they no longer a patient of the provider? We found that the majority of states or jurisdictions don't actually define patient in their practice acts. So I thought that was a really interesting finding. We make a lot of assumptions that everyone understands who a patient is and when they are a patient or not. Next slide. So then we wanted to find out more about, is there language that suggests the patient relationship continues after they're discharged from your care as a provider? And again, the majority of the jurisdictions do not have any defining language in the Practice Act that clearly specifies that the provider-patient relationship either continues or ends after that last treatment day. Next slide. So our takeaway tip would be to consider looking at this topic in your jurisdiction and if this is something that you should consider, or if you would have a need to address this. And again, you'll have a better idea from how many of these violations are being reported or things like that to know if these are the types of things that would really help for you to have clearly defined in your laws and rules. So consider reviewing if the language would require a future change to be able to clearly define who the patient is, who the provider-client relationship is, when it begins, if there's a timeline associated with it, and when that relationship would end, if ever, or if once your PT, they're always your PT. They're just like your primary care physician. You plan to go back to them if you have a future need. So we were able to find some nice examples in a couple of the jurisdictions' websites. And if you look, Arkansas and Idaho here on this slide do put a time frame on their patient-client relationship. So 6 months or 12 months, those are common things that we found, that you cannot have a relationship, a sexual or romantic relationship with a patient until at least a certain amount of time like this has passed. But the District of Columbia here in the middle gets a little bit more in depth at looking at describing you can't have a relationship with someone who may still be vulnerable to the power imbalance that existed by you being their provider, their healthcare provider, which we really found that language to stick out to us and really reflect some of the deeper issues, I think, that we had trouble articulating. Why is it difficult to condone a relationship even after they're no longer a patient? But this kind of starts to emerge as some of the reasoning behind that, because there is a level of vulnerability for that patient when you have been in a position of power almost over them as their healthcare provider. Next slide, please. So then we looked a little bit more into some of this language, and we have Louisiana and Virginia here go a little bit further into this idea of this relationship and this conduct exploiting the trust that this individual has put in you as their provider. And if you are having a relationship with them, you're in a position to exploit their trust that they have put into you, or the knowledge, the influence, the emotions derived from that professional relationship you had with them. New Jersey here in the middle was one of the shorter time frames that we saw. This one has no more than 3 months since the patient-provider relationship existed. Could there be a relationship? Next slide, please. And then Washington it looks like has kind of a combination of several of those things. It has a little bit of a time frame of a 2 years out from the patient-client relationship ending, but then also addressing that idea of having a balance of power or an influence over that relationship as well. So it looks like they're combining both a time frame and this concept of power. So those are some nice examples of our US jurisdictions and what we found in some of our research of the Practice Acts. But then we have some nice examples from our international partners as well. Again, similar timeframes, things like a year or so. Next slide. And then we have Ontario looking at that imbalance of power in addition to the 1 year. But then New Zealand's example says it's really never acceptable when the patient was discharged if you're discharging them only to have a relationship with them. That would never be acceptable. And that was something that came up in some of our conversations too, in our jurisdiction at this level. Like, if you set a time frame and you say 6 months or a year and you discharge them, and then you say, hey, you want to go grab drinks after this? I've technically discharged you, but I just discharged you. So now is it okay because you're no longer my patient? This kind of addresses that. If you're discharging them only so that you can start a relationship, that would not be appropriate or acceptable. Next slide. So the takeaway tip, these are just some things to think about. We don't necessarily have a set idea of this is what definitions you should have. These are the types of things you should have it say. But we wanted to start the conversation to get jurisdictions thinking about what makes sense, and should we have a larger conversation about the pros and cons of using some of these definitions, like who is a patient? When does the provider-patient relationship begin? Does that relationship continue even after you've discharged the plan of care? And then when does that relationship end, if ever, like we mentioned, or if they had another need for therapy, they would most likely come back to you. So in that sense, you're never really not their provider anymore. So there might be room to develop some messages and resources to help both the public and our licensees better understand the issues and the rules related to some of these things by clarifying our language. All right, and I'm going to have Kristina talk to you a little bit more about the next topic.
All right, so we're going to talk about identifying potential barriers to investigating violations. And when we started this, we were surprised that it's not just about regulators. Like, how do we make these easier to investigate? It happens at all levels. And so if we go to the next slide, this is an interesting poll question. So, are you aware of a sexual misconduct or boundary violation in the workplace? So if everybody could start answering that, because I'm really interested in the results. This doesn't have to be related to physical therapy. I mean, it could be in the classroom, it could be in the office, the hospital. I mean, some of us may know family members from personal experience that were violated in some way. And so just do you have knowledge of it? Are you aware that this happens? And so it looks like most people are saying yes. Give it like a minute more, get a couple extra people in there. Okay, so 44% know of it happening more than one time. Okay, which is kind of astonishing. But if we go to the next slide, we'll actually find that they did a research study in 2007, and they found out that 38 to 52% of healthcare professionals report knowing of colleagues who have been sexually involved with patients. So actually, our poll results are right in that percentage. So it just kind of reaffirms that maybe things haven't changed so much since 2007. So we know about it. So who are the stakeholders moving forward, right? We know it's happening, we know it's a problem. And the truth is that we all are, because the physical therapists need to know about it, patients need to be protected, students need to be educated, and as regulators, we need to know how to handle these situations. And so now that we know it's a problem, what are some things that we can do about it? And if we go to the next slide, first thing we can do is go back to Jennifer's original opening slide and maybe promote the duty to report a little more. I mean, 44% of us have known of an incident or more than one incident happening. If we promote duty to report a little more, the chances of this happening in the profession or even repeat violations happening would go down considerably. So one of the first things that we said was, going back to printing out the handouts or flyers or posting something on the websites or adding it somehow to the PT education and putting a real focus on the duty to report, I think would be helpful. So in the next slide, another poll question. So where have you learned about how to avoid or appropriately deal with sexual misconduct and boundary violations? And you're going to click all that apply. So where have you been exposed to education, resources, conversations about sexual misconduct and boundary violations? Good, and it's changing. Good. That looks really good. And a lot of people are responding. So a lot of people must have some experience in this. So obviously our regulatory boards provide a lot of that education, workplace. I'm excited that a lot of people are taking continuing ed in this subject. That's amazing. Keep it up. And then, you know, school, we find that that usually is one of the places that doesn't get quite as much yet, but we're hoping to put that up. The schools are doing a good job about trying to start implementing some of these things. But overall, yes, this is a good reflection of what we were hearing in the public. So let's go to the next slide. All right, so let's talk about some of these stakeholders a little bit more. And obviously we want to start with physical therapists. And when we did the website reviews, we pulled up various cases from different states and just kind of looked at some boundary violation examples. And one of the questions that came up was this idea of I didn't know. You know, I didn't know that that would be offensive. I didn't know that I couldn't do that. I didn't know that, you know, we weren't supposed to date. Oh, back to the other slide, I'm sorry. And so we're going to figure out why is it that they didn't know? You know, can we address that? And so it does make sense that they didn't know, because in the classroom as a student, I mean, it's been many years ago, but I remember the first day of lab, you go in and you're told one layer of clothing. We're going to palpate, we're going to go through, we're going to learn these landmarks. And so take it off and let's get started. And it was incredibly uncomfortable for about 2 weeks. And then over the next 2 years, I mean, you just go in and automatically do it, right? It becomes routine, and we're not as sensitive to the issues anymore. We don't realize how uncomfortable that made us in the beginning. So I think that's just one example of starting with the PT students that we could start incorporating into the classroom. And we could look at starting to initiate those conversations, explaining a little bit more of why you're disrobing or why I'm looking at this part. So that was one of the things that we found on I Didn't Know. And then a couple of other things, hands-on profession in the digital era. So we have come to the point where most people communicate by some form of social media, right? So we text message each other. Kids are not necessarily in the same room visiting. We have all these apps and different things that bring us together without being in each other's space. And so I think that's something that we need to be aware of as we move forward, that perhaps people aren't used to having someone in their space as much as it used to be in the past. And then of course, in the post-pandemic era, we've got to realize that a lot of people have really been avoiding personal contact, and some of that has still carried over. And even in medical professions, now that we've gone to telemedicine, some people haven't actually been touched by their physician in 2 years. So when they come in to see you, it could be a little bit, there could have a little bit of miscommunication or be uncomfortable in that situation. And so that brings us to the importance of ongoing patient consent. So usually when a patient comes in, we give them a consent form and they sign it, or we explain one procedure and get their consent. But we're finding with these social changes, the changes in culture, it's more important to have ongoing patient consent. And so that's something that happens every visit, and helps us become more familiar with what the patient is comfortable with, and helps the patient become more comfortable with the things we need to do in the clinic. So if we go to the next slide. So then we start talking about the patients, right? The patients are also stakeholders, and they are also ones that say, I didn't know. So I didn't know that that wasn't appropriate. I didn't know that I could say something. I didn't know I had a choice. So we need to be aware that this is a completely new experience for some people. They've never been to physical therapy. They don't know what to expect. So therefore, one of the examples is we could give out handouts or put on a website, you know, what to expect when you come, and what is normal routine physical therapy practice in terms of disrobing and those types of things. I think the PT asking permission to discuss medically sensitive information and giving the patient permission to do it, and let them know that it is confidential and that, that it's not something that you're going to disclose to others. And then, as we talked about before, how to report a violation. That's very important for the patients to know as well. Even just knowing how to do that and making it public, clear somewhere, gives somebody a sense of empowerment, right? So even if nothing happens and they never do it, just having that knowledge gives them a sense of autonomy, that they have some control in this relationship where there is already a power differential. So if we go to the next slide, so the next slide is an example. Oops, no, this is one too many. Go back one for me. Oh, maybe it's not on there. So, but there is an example of a patient handout. Physiotherapy Alberta actually made one that they give, that you can hand out to your patients, that does exactly that. It says this is what to expect. This is appropriate touching. This is inappropriate touching. And those types of things. And it says in it actually how to file a report, file a complaint, and those types of things. So other jurisdictions are coming up with ideas of how to empower the patients. So let's talk about the regulators, right? Because they're the ones that are going to be investigating this. And it was interesting because Jennifer comes from Ohio and I'm from Louisiana, and we found that it's completely different in who investigates these complaints. So for example, in Ohio, they have an investigator that does that full-time for them. In the state of Louisiana, as a board member and a physical therapist, I am the investigator. I have help, but I am the main investigator. So that is two completely different ways of doing things. And so it makes a difference, right, on the level of education you need moving forward. So for regulators, I mean, obviously the first thing to do is that go back and review that language and make the definitions clear. I mean, who is a patient? That's important. And when did, the patient provide a relationship, make everyone aware of the dynamic. This on the screen is an example. So what happened is the National Council of State Boards of Nursing came up with this evaluator criteria, and they used Idaho as their prime example. So I put that up there just to give an example of what they consider like baseline requirements for an independent investigator to handle a boundary violation case. And that is a lot of requirements. I mean, you have to have 250 hours of offender evaluation experience. You have to have continuing ed of 40 hours. So this is an example of what some boards are starting to require of their investigators, and shows us maybe where the direction we need to go. This may be an extreme example, but shows us that there is some room for improvement out there in determining who investigates these cases. And you go to the next slide. Okay. So the question is, do you know of any resources available for investigative training? So do you guys have any access? Clear, yes. So we have, I reached out to Charlotte in Louisiana, and they do the CLEAR training. They also do a program called Justice 3D, which has worked really well. And they use outside investigators. Yeah, so it's a lot of no's though. So hopefully, that's something as a resource, if needed, that we can put out there, is where can you as board members get some of this training from, and how do we make it available to where everyone can access it pretty easy. Okay, I did find, which was really interesting is the International Association of Chiefs of Police actually have their training online that they can open up to anybody to take. It's a lot of training, but I mean, that's upper level, just to go through and kind of look at and learn how to interview a victim, learn how to interview a suspect, and those type of things, just key points. All right. Oh, I like that, trauma informed from mental health department. Okay, let's go to the next slide. So takeaway tip. So education is helpful at all levels, right? We want to review the available resources in your practice setting. And in those resources are boundary issues discussed. And do you have a place to go to ask questions? All right, I'm going to turn it back over to Jennifer.
All right, let's go to the next poll here. We want to know if your board or workplace currently has educational materials in your workplace related to sexual misconduct or boundary violations for your workplace that you're aware of. So it seems like this is a growing area, that more and more workplaces and employers are identifying the need for some policy or procedures and education materials. So that's great that it's such so many of you are saying yes to this. A handful are not quite sure, which is valid. All right, so it looks like the majority do have some materials related to education in this area. That's great. Let's go to the next slide. We did find that some of the jurisdictions are utilizing educational materials in the format of videos, some newsletter articles, and some frequently asked questions seem to be some of the common ways that we're seeing educational materials being presented. Next slide. This is from the Don't Cross That Line webinar, but the education by regulators raises awareness for the uninformed. And if regulators can provide this information, they can affect the decisions practitioners make and therefore change the patient experience and protect the public. And the question that we asked earlier was, where are you getting some of this information from? And many of you answered that it was the regulatory boards is where you go to get this information. Just highlights this. And our role as regulators in having this information available and being able to direct people in this space. Next slide. So when we looked at the different types of education that we wanted to put out for different stakeholder groups, we were able to categorize some of the existing resources into three main areas. The first group is materials geared towards the licensee or the student who's about to be licensed. And some of the examples, again, from Physiotherapy Alberta, who has a lot of great information in this area, along with the Medical Board of Australia and the Chartered Society of Physical Therapy, along with Louisiana. These are some links to some of the materials that are already out there geared towards this population of licensees and students. Next, the category was for the public or those consumers. We have a little bit again from a couple of those same areas where you can kind of click on either the resource materials or video. And then the final category were resources for regulators. So those in the position to investigate these reports. So again, you have CLEAR, which we heard before, a lot of people are already utilizing as a resource, but also some other resources across professions like nursing and medicine. So check out some of these if you're looking to tweak your education materials towards specific population groups. Next slide. So our takeaway tip from these findings was we are in the position to be identified as a valid, reliable source of this good information. So we are in a position to develop messaging and resources to help the public and our licensees better understand these issues and the rules related to it. Next slide. So we talked about what we've done over the last couple of years. So where are we going next? Well, next slide, we have some of the recent webinars around the same topic. So one was about the pelvic health and internal examinations and changing the regulation of physiotherapy practice in Alberta. The Don't Cross That Line, which we've mentioned and referenced several times. It's an excellent webinar. I encourage you to watch it again if you haven't seen it. And then exploring the challenges of regulating a hands-on profession in a hands-off area. These are all great resources that are currently available. Next slide. We've also transitioned from a task force into a standing committee within the Federation. So we are now the Sexual Misconduct and Boundary Violations Committee with a website on the FSBPT webpage. So check us out there and you can see some of this information, and that's where you can go to get the future information and materials as we continue to develop and compile this information for you. Next slide. So as a committee, some of our springboard ideas to take us into the next year or so are to really look at this idea of the power differential. That was such a striking topic that we found when we were reading those sections of the jurisdiction's laws that actually refer to that in their law. So we're gonna dig deeper into that and provide a resource for your jurisdiction around that concept. Also looking at disciplinary action or training courses. So what do we do when we're looking for remediation resources in this space and once the investigative process has gone completed, and then what do we do for discipline for these individuals? Looking at developing language for the Model Practice Act. If you're looking at maybe updating your Practice Act or maybe coming into line with what some other jurisdictions are doing or the language that's been useful, we hope to provide some ideas and examples in the Model Practice Act for some of the topics that we mentioned that could provide some consistency for us. Again, develop more education materials across all those different avenues of formats and for the different populations that might be most benefit most from that material, and adding some questions to the licensing exam or increasing the student education and emphasizing the importance of understanding these things. So there's no more of that, well, I didn't know type of thing that to avoid that in the future. So let's go to the next. We have our last slide. Given everything that we've discussed today, in just one or two words, if you could summarize some takeaway ideas or concepts that we were able to help spark in you today, put that in here so that we can see kind of where everybody's landed with all of the information we've talked about today. Training, resources, review materials, quick links, power, ongoing education, more work to do, assess what's currently happening, review, clear definitions, lots of work to do. This is really great. It's been really helpful to kind of hear your feedback and comments. I saw the comments about informed consent and consent to treat and the difference between consent to treat and informed consent, and so many different avenues. We could keep talking about these for so much longer than we have together today, but I really appreciate your engagement and your ideas. check the website. Resource links. These are great. All right.
Thank you so much, Jennifer and Christina. That was an excellent presentation, and it unfortunately it brings up more than it solves, right? It shows how little information is out there training. I mean, what I heard loud and clear is that the whole training. I mean, I wrote down regulators, educators, patients, investigators, practitioners. There's so many levels of training. So where do people start? Like where, you're sitting on a board. Where does your board start? In your opinion, this is all now opinion, right?
Yeah, so one easy place to start that we kind of saw from our polling and our research in the websites was just some clear definitions. Maybe that's one simple thing you could start with. Just look at your language. Maybe it's the language on your website, maybe it's the language in your practice act, but are you clear in the language that you're using, whether that's the language for how reporting is being done or language and how things are being defined in your practice act. Maybe that's a simple review process and maybe won't be as overwhelming as some of the other steps in the cycle.
Right, and I did appreciate that you mentioned the Model Practice Act, which of course is going to be some new work being done on that, and this is great timing on the work of this task force and now committee to make that part of that. Kristina, did you have any comments?
Yes, I think definitely the definitions are important. I think also, I mean, the easiest way to start is duty to report, right? Because if we know about it, then we should report it. And I think as a duty to report, you become more aware of maybe how you practice as well and how it's kind of just prevalent everywhere. I also think patient education is important to kind of avoid all this happening to begin with. I can't remember what resource it was, but I found that 1 in 3 females has been a victim of some type of boundary violation before they even come into your clinic. So, they bring in their own history, their own experiences, and it does affect perception, and it does affect how they interact and how they perceive what you're doing. So I do think that there's an importance in focusing on the patients and that we could maybe disperse that information pretty easily through the clinics.
Yeah, I totally agree. I think that people have no idea how frequent this happens in people's lives and don't know, they don't understand who their patient is. And it does protect the practitioner. There's been experiences that cases I've heard of practitioners being put into a bad situation because of just not realizing and then being put in a bad situation where they may be accused of something. So the whole issue of power imbalances, do you think that our practitioners understand that?
I don't think so. I was shocked just reading what some of the other organizations and boards have done or how they define that power differential. When the physicians, the Federation for the Medical Board, Federation of Medical Boards, they put out their position statement and they said that it is just innate to the profession. As soon as somebody walks in your clinic, as soon as they provide any type of medical information to you, that the power differential is just already in place. Being subjected to a physical exam, being asked to disclose medical history, being asked to describe symptoms. And I never really thought about it like that beforehand. So I do think that that's something that we as practitioners maybe aren't as aware of.
Mm-hmm.
Yeah, absolutely. And I think that level of almost intimidation, right, that a patient could experience from like, well, this is the professional, I can't really say anything, I can't really speak up because they're the professional, what do I know, type of thing is sometimes what we see or hear. And that clinicians need to be aware of that potential perception.
Yeah, I agree. So do you think anything's changed in this world that why are we seeing more boundary violations, or why we, there's a good philosophical question to end up with.
I feel like,
I mean, in the years of my practice, right, this is a growing concern, and serving on a board, there's absolutely a growing concern. So where's it coming from?
I'd like to think maybe it's just being identified and reported more now, and that's why it appears the statistics are higher.
I agree with that. I think it's just people are more comfortable with talking about it.
Yeah, very good. So I want to make sure that people are posting on the discussion if they have any questions. Actually, someone just did post, I think it's always been there, but coming to light more, which I would agree with. Any other comments people have they want to put on the chat room? But, it's all about empowerment, right? It's empowerment of our practitioners to keep their boundaries. It's empowerment of patients to know what their rights are. There's a lot in there. Do you have any other final comments you want to make before we end the time?
Not really. I would just maybe in the chat room to say what you're most interested in us pursuing. Like, what's the important thing to people watching this right now? What are they wanting first? What would be the most helpful?
What would be most
please.
useful for us to focus our efforts on next?
Because we do keep save the chat. So and absolutely, I do get the pleasure as a board member to be a liaison with this committee, and absolutely that was where we kind of ended the conversation. There's this huge pile now. Where do you start? So if anyone wants to add to the chat comments about where they think the priorities should be for this, for this committee, for the Federation, that would be great. Educating students, absolutely. So thank you from Bob Frampton. Thank you to our presenters. Yeah, I mean, if we start with our, incoming practitioners, certainly that's a place. Remediation options for licensees who have violated and weren't aware. The I don't know people, which I think genuinely some people don't realize. So I want to thank the presenters, Kristina and Jennifer, for all your hard work. We want to make a special thanks to Jennifer as she is moving to Sweden because of her husband's work, and she will be leaving the committee and the leadership of this committee. So we appreciate all your hard work, your time today, getting ready for this presentation, and a wonderful presentation. And I wish you all the best for sure.
Thank you.
Please, when you come back to the States, come back to us.
I will.
So we want to thank everyone for your contributions today, your interactions by Slido, and we hope you have a good day.